Hello, my name is Guillen, and today I will be discussing our study evaluating changes in testosterone in men treated with GLP-1 receptor agonists. In a nutshell, GLP-1s have rapidly become one of the most important therapeutic classes in metabolic medicine, and while their effects on glycemic control and weight reduction were established, much less is known about their impact in men's health. This is particularly important because obesity, insulin resistance, and metabolic syndrome are strongly associated with functional hypogonadism and reduced testosterone levels in men. Improvements in testosterone in obese patients is often attributed to weight management, potentially involving changes in insulin sensitivity, inflammation, adipose tissue dysfunction, and as well to the regulation of the HPG axis. With that in mind, we aim to evaluate changes in total and free T after the initiation of GLP-1 therapy. For this, we perform a retrospective analysis of obese men treated with GLP-1s from 2018 to 2025, who had both pre- and post-treatment testosterone measurements available in their EHR. For our primary analysis, we evaluated changes in total and free T using non-parametric testing, and we then perform an adjust linear analysis controlling for age and baseline BMI. In total, we identified paired total testosterone data in over 1,600 men and paired free testosterone data in more than 1,200 men. At baseline, patients with lower BMIs tend to have higher testosterone levels overall, which is consistent with prior literature. And after GLP-1 therapy, however, we observe a significant improvement in both total and free T levels. Median total testosterone increased from 320 to 419 nanograms per deciliter, representing an increase of approximately 99 nanograms per deciliter. Similarly, median free T increased from 9 to 10.4 nanograms. Importantly, these findings remain statistically significant even after our adjustments for age and baseline BMI in the mixed effect model. One of the most interesting findings from our study was that changes in testosterone were not directly correlated with BMI reduction alone. What this suggests is that the hormonal improvement observed may not be explained solely by weight loss. Our leading hypothesis is that the testosterone improvement is slightly multifactorial. Weight reduction and reduced adiposity probably contributed significantly, but additional mechanisms may also be involved, such as improved insulin sensitivity, reduce inflammation, reduce aromatization for the adipose tissue, and potentially a restoration of or an improvement of the HPG axis. I will be cautious about claiming a direct central HPG effect at this stage, but it's biologically plausible and certainly warrants prospective studies. Clinically, I think that GLP-1s may eventually emerge as an adjunctive strategy for men with functional hypogonadism related to obesity and metabolic disease. However, I will not frame them as primary or as a replacement for standard hypogonadism management, but rather they may function as an aid or as a disease-modifying metabolic therapy that improve secondarily this hormonal milieu in these selected patients. Of course, our study has several limitations. This was a retrospective analysis, testosterone measurements were not standardized by timing, causality cannot be established, and therefore residual confounding also remains plausible. Nevertheless, our findings suggest that GLP-1 arrays may have favorable effect in these male patients, particularly in obese and metabolically complicated men. As the use of this medication continues to expand worldwide, understanding their broader implication in men's health will become increasingly important. Thank you very, very much for your attention.